At the end of this lecture, you should be able to suggest the initial settings for patients commencing mechanical ventilation, suggest changes to improve carbon dioxide elimination and oxygenation, explain how to optimize trigger function on pressure support ventilation, and describe the MSS assessment, movement, sound, saturation, whenever invasive ventilation is commenced or changed on a patient. Okay, we're going to start by making you think for a minute. Look at the questions on the slide and think about your answer. The aims of mechanical ventilation are to get oxygen in and carbon dioxide out while minimizing adverse effects and maximizing patient comfort. We're going to talk through a couple of cases to show you how to apply the knowledge you have already obtained by reading your course manual. The details of the first case are shown on the slide. What are we going to set on the ventilator? When considering mechanical ventilation, always consider whether non-invasive ventilation would be appropriate. This is clearly not appropriate in this case as the patient is apneic. Possible invasive modes include one of the assist control modes or SIMV. Pressure support is not suitable at the present time because the patient is still paralyzed. Remember that in most cases, your familiarity and the other team members' familiarity may be the most important factor. In this case, we decide to use volume preset assist control mode, which means that we need to set the tidal volume, respiratory rate, PEEP, IE ratio, inspiratory pause, and FiO2. The idea is to set something reasonable and then adjust based on your assessment of the patient. As you will have read, we usually set the tidal volume between 6 and 8 mL per kilo predicted body weight. In this case, we have set a tidal volume of 500 mL, which is approximately 7 mL per kilo. We don't think the patient is likely to have a very high metabolic rate, so we can set a normal respiratory rate. Nor do we think he's likely to have major issues with oxygenation, so we can set a relatively low PEEP of 5, IE ratio of 1 to 2, and an inspiratory pause time of 10%. To err on the safe side, we will set the oxygen concentration to 100% initially, tailing it down rapidly once we've established that he does not have a major oxygenation problem. What would be your next step? Whenever we apply a treatment or change a ventilator setting, it is vital to assess the response. Do an MSS assessment. Look for chest movement, listen to the chest sounds, and look at the saturation. A blood gas is also useful, but you need to wait for about 20 to 30 minutes before the PaCO2 will equilibrate and reflect the adequacy of ventilation. So here is the blood gas. What would you do in response? The PaO2 is very high and the oxygen concentration can be reduced. He has a respiratory acidosis with a raised PaCO2 and the alveolar ventilation needs to be increased. This can be achieved by increasing the tidal volume or increasing the respiratory rate, or both. Increasing tidal volume increases alveolar pressure and risk of barotrauma, while increasing the rate increases the risk of gas trapping. So what should we do? The answer is the solution needs to be individualized for our patient. The plateau pressure is already quite high. We aim for less than 30. The risk of gas trapping in a patient who does not have obstructive airways disease and has a respiratory rate of 12 is low. So we will increase the respiratory rate and decrease the oxygen concentration. The patient starts to wake up and make spontaneous breathing efforts, which is dysynchronous with the ventilator. So we decide to change to pressure support. We need to set the level of pressure support, PEEP, FiO2, and trigger sensitivity. The lung compliance has improved and the plateau pressure has now fallen to 20. As a result, a pressure support of 15 above PEEP of 5 should generate similar tidal volumes. Oxygenation has also improved, so the FiO2 can be further reduced. The PEEP is relatively low and can be left at 5. We want the patient to be able to trigger the ventilator easily, so it is set to flow triggering. The trigger sensitivity determines how easy it is for the patient to trigger the ventilator to deliver a breath. In general, increased sensitivity is preferable to improve patient-ventilator synchrony, i.e. to stop the patient fighting the ventilator. It may result in false or auto-triggering, i.e. the ventilator detects what it thinks is an attempt by the patient to breathe, although the patient is apneic. Triggering may be flow-triggered or pressure-triggered. Flow-triggering is generally more sensitive. The smaller the flow or the smaller the negative pressure, the more sensitive the trigger. Again, after changing a ventilator setting, it is important to reassess the patient. As well as looking at measured ventilatory parameters such as respiratory rate and tidal volume, also check that the ventilator breaths are well synchronized with the patient's efforts and repeat the arterial blood gases. Okay, let's pause for a minute while you think of 2 important points you've learned so far and why they are important. Now we're going on to our second case. How would you ventilate? We decide to select pressure control mode with an initial FiO2 of 1 and initial pressure of 10 above PEEP of 5. In pressure control mode, we have to estimate the appropriate pressure and then adjust according to the tidal volume, chest movement, and PaCO2. In this case, the tidal volume is only 200 mils, approximately 3 mils per kilo. Therefore, the pressure needs to be increased. And with the increase in pressure, the tidal volume increases to 500 mils. However, the saturation is poor, and this is confirmed by an arterial blood gas. Under normal circumstances, we would increase the FiO2 while looking for and correcting causes of desaturation, but the patient is already on 100%. Our initial response should be to look at the patient and check that the chest is moving and moving symmetrically. Then listen for breath sounds to confirm symmetry and to detect abnormal sounds. Only after this should we look at the ventilator for evidence of ventilator malfunction or inappropriate settings and get a chest X-ray. While treating any underlying cause, there are a number of ventilator changes that may improve oxygenation. The FiO2 is already 100% and so cannot be increased. Increasing the inspiratory pressure would increase the mean alveolar pressure and improve oxygenation, but would increase the risk of volley trauma and barotrauma. And the tidal volume is already 8 mils per kilo. Increasing the inspiratory time would increase the mean alveolar pressure, but might cause patient ventilator desynchrony or gas trapping. Increasing the PEEP is probably the best option, as the current level of PEEP is relatively low. Again, we need to reassess the patient after making any ventilator changes, including checking the oxygen saturation and the arterial blood gases. Okay, before our final summary, I'd like you to write down 3 things you learned from this lecture that you think are important messages, perhaps things you would tell a colleague who hasn't heard the lecture. To summarize, choose the mode that fits the patient, but take into account your familiarity with the different modes. Tidal volume or respiratory rate change the PaCO2. FiO2 and PEEP are the best options to improve the PaO2. Changing trigger sensitivity can improve patient ventilator synchrony. Watch out for high airway pressures. Do a MSS assessment after every ventilator change. There is often more than one way to achieve your aims. Select the method with the least adverse effects.